All right, we're going to get started for talking about the payment changes that we recently found out about this past beginning of the month, and as they relate to glaucoma. I'm Cindy Mattox. I'm the American Glaucoma Society Vice-President, and I've also been a member of the Academy's Health Policy Committee, advising on glaucoma issues for 11 years now. And we have George Williams here as well, who's the Secretary for Federal Affairs for the Academy, and also is the Academy's RUC representative, and actually sits in deliberation at the RUC for all codes except for ophthalmology codes, where he has to recuse himself. So let's talk. Oh, did I lose my microphone here? So we're going to talk a little bit about how this all came to be, and just to back up a little bit about how a code is valued. When we have a procedure or an exam code, it goes through what's called the resource-based relative value scale, and CMS takes the value for a CPT code based on 3 different factors. And it's physician work, which is called the work RVU, practice expense, which is the practice expense RVU, and a malpractice expense, which is a small proportion but does affect the value of a code. Based on these 3 factors, Medicare then converts it to dollars based on a conversion factor that is adjusted every year, or last year was adjusted in 6 months. And that conversion factor comes out every year. It has to be budget neutral. So the conversion factor is determined, the combination of the RVUs is multiplied by the conversion factor, and that's how you get the payment rate. There are various regions that have different geographic differences based on salary structure for your staff and cost of living and all those sorts of things. Medicare assigns a geographic variation. So when you see the values that the Academy publishes, there's always going to be a slight difference between that, what's published for the Academy, and what is happening in your city or town. The RUC committee that creates the value that is presented to CMS is made up of 31 volunteer physicians from all specialties across medicine, including primary care, and CMS then charges the RUC with a group of codes that they consider misvalued. And the societies that are targeted, their codes are targeted, go through a process where they are required to get surveys out to their membership, random surveys, tally the responses, and present the codes to the RUC, and then CMS gets the final say on whether the values that the RUC committee comes up with are what will be accepted by Medicare. And I'm sure some of you have probably been participants in the surveys, and the surveys ask you about the time it takes to do your procedure, the intensity of how much skill is required for the procedure, and what the risk is to you if you have a poor outcome. Then based on that information, you are asked to compare the code that's being under consideration with a list of codes that already have assigned values, and you pick a code out of that list to say, yeah, well, this one's just about like this code, but it's a little different in this way or that way, and that's how the survey is completed, and then it's tallied up in aggregate to present to the committee. So the final rule is Medicare's final rule is presented every year at the end of October, and the codes that are valued in that final rule are then implemented January 1st of the following year. And in this year's final rule, the impacts for ophthalmology were primarily for retina and glaucoma surgical codes. And overall, the 2016 Medicare revenues in general for all of ophthalmology are projected to be minus 1%, but as you will see, retina and glaucoma were differentially hit much, much more. Part of the information and background is that other specialty societies surgical ones in particular, have been particularly hard hit over the past 5 years or so, and ophthalmology has been relatively spared compared to other specialties like cardiology, interventional radiology, and other GI specialties, for example. So the conversion factor for 2016 is actually a little less than we expected. Some of you probably remember that in the MACRA law that went into effect that repealed the SGR, we were told that we would get a 0.5% increase in the conversion factor every year for the next 10 years. Well, that only goes into effect if CMS successfully reduces physician payments by $1 billion annually. And if they don't come up to that $1 billion target, then that 0.5% is off the table. And in fact, in this, it can be less. So this coming year, 2016, the reduction in the RVU conversion factor is off by 0.79%. And so we really will still have a reduction overall. The targeted cuts are, again, to retina and glaucoma. This is what I mentioned earlier, that many other specialties, this might be a little hard to read, but cardiology has been effectively cut 14%. Radiology is down 77% over the last few years. Radiation oncology, 19%. But look at ophthalmology, 0% over the total 7-year impact. So we were definitely targeted because our specialty has had less pain than many other specialties around. But look at the primary care codes. The CMS is very aware that primary care needs to be incentivized. That's what the administration wants. That's what CMS is charged with doing. And look at how primary care, family practice, and geriatrics have actually had increases overall in the value of their services. So let's talk about glaucoma surgery. The 2 glaucoma codes that were targeted by a screen from CMS were targeted because they have such a large number of post-operative visits. And there are many, many reasons that a code can be targeted, but these 2 were targeted because of that. Trabeculectomy 66170 and 66172. Laser trabeculoplasty 65855 was also targeted because of a high number of postoperative visits in the 10-day global. So that's why we had to submit these codes for valuation. This is what happened. The current work RVU, remember this doesn't have practice expense or malpractice RVUs in it. Current 2015 is 3.99. Based on recommendations and survey results that reduce the number of post-op visits and the time involved with laser trabeculoplasty, the RUC valuation for that big committee that we were talking about reduced the RVU value for laser trabeculoplasty to 3.0, and then CMS in the final rule said, well, we don't really like that. We think that's actually less than that, and CMS decided what we feel relatively arbitrarily, that the cut should be further down to 2.66. So for 2016, if there's any little glimmer of happiness in the news I'm giving you today, it's that the CMS is required now to not implement the entire cut in 1 year. The maximum they can do per year after a code is revalued is a 19% reduction. So in 2016, we will see a 19% reduction for laser trabeculoplasty, but the balance that's left over that has not been implemented will be implemented in 2017. So the pain is spread out over 2 years rather than 1, but it's still going to be painful both years. Trabeculectomy, the current work RVU is 15.02. We recommended a decrease to 13.94, or the RUC recommended after our presentation. Basically, we were able to defend trabeculectomy. The number of post-operative visits actually is the same as what the original code was, but because of the trabeculectomy was not valued This family has not been valued basically since the RUC process was in place about 22 years ago. So it's true that the time involved with our procedure on the survey results was reduced from 60 minutes down to 45 minutes for your typical trabeculectomy, so they took that into account. They also, in the old days, the value of the postoperative visits were much, much higher level codes that were incorporated, and now they just don't do that anymore. You get a relatively high level 3 code if you do a dilated exam, but not all our postoperative visits are dilated exams, and the balance are level 2 codes in the postoperative period. So based on that time reduction intraoperatively and the value of the postoperative visits being reduced, the RUC recommended that decrease down to 13.94. So it was a small decrease in the work RVU. In the final rule, CMS said, well, hey, we're going to do this fancy calculation and base it on simply the amount of time that reduction in the code value, and we're going to reduce it even further because 13.94 does not reflect a 25% decrease in the time like you told us the time was reduced. So we're going to reduce it down to 25% lower, and 25% lower ends up being down at 11.27. In other words, CMS ignored the RUC process, they ignored the RUC valuation, and basically said all the reductions should come out of how long it takes you to perform this service. So in 2016, the reduction will be 19%, and there's obviously a little more that will happen in 2017 for that. 66172, which is the complex trabeculectomy, took a much bigger hit. It's notable for you all to know that I don't think there's any other codes in all of medicine, is that true, George, that have except for cataract and trabeculectomy, that have a complex and a standard procedure. Very few enjoy that designation where we can say, well, yeah, this dissection is extra super hard for these patients, so we should get paid more, because most of the codes are valued on the typical patient. But anyway, we do have a complex trabeculectomy code. The original number of postoperative visits was quite high, and we could not justify quite as many postoperative visits, and the value of the postoperative visits, as I mentioned, the levels have gone down, and the time for doing a complex trabeculectomy in the old days, 90 minutes. No survey results supported that it takes 90 minutes to do a complex trabeculectomy. So the survey showed about 60 minutes, and that reduced it down. So the RUC recommended 14.81, and CMS, again, used their calculations for based on time-based reduction to justify an additional reduction, again, ignoring the RUC valuation and putting in their decision that the value will be 12.57. So in 2016, the payment reduction will be 19%, and an additional cut, now I think wasn't that a typo? I think it's another 11%. Okay, in the 2017. So 2017, it'll be not an additional 22%, it'll be additional 11%. So the Academy is partially responsible for these values not being, having the full 100% cut being implemented in 1 year. So this 2-year phase-in, like I said, is a little glimmer of light. And retina, as you've heard, is also taking big hits. So if it makes us feel any better in the retina area, they also took some big cuts. Okay, all right, so we're happy to answer any questions about the process, anything that we can try to explain better. George is the RUC expert, and I'm happy to chime in if there's something I can answer too. So there's some microphones set up in the aisles if anybody wants to have a comment or question. Yes.
Hi. I believe the tube codes were done a couple years ago. The severity of the reductions, are they similar this time to what they did with tubes? I just don't remember.
Yeah, so the tube shunt, aqueous shunt 66180 and 66185. So what happened with those codes, they actually came up about 4 years ago. And the reason they came up is because Express Shunt 66183 was part of that family. And the rules for the RUC now require that anytime one code of a family is identified as potentially misvalued, the entire family has to be surveyed. So when 66183 came up, that's how the other two codes got swept up in it. Then what happened is that CMS showed us some data that the patch graft code 67255 was coded simultaneously with 66180 or 85 70% of the time. Whenever they see that kind of combination going on, they realize that it probably should be a bundled code, and the codes were sent back to the CPT committee to revise the terminology of the codes. And so the code cuts that happened to aqueous shunts should have happened about 4 years ago. As it turned out, it happened in 2015 because of this delayed process of having to get the codes redesigned by CPT. So now we have the aqueous shunt codes that are been revised. There's a code for the aqueous shunt without graft and a code for aqueous shunt with graft, and similarly for the two revision codes. So we took a big hit on those basically because we can no longer bill the patch graft along with it. But the codes themselves, if you look back, the value didn't change all that much if you weren't using a patch graft. So that happened in 2015. So yes, our aqueous shunt codes were cut during that period of time. Now the trabeculectomy code. So that's why we're feeling so embittered and targeted everything we're doing. So any other comments or questions that we can answer? George, anything you want to add?
Thanks, Cindy. First, I'd like to tell the glaucoma community how well represented you are by Cindy Mattox's efforts. She's been a great resource for everyone in ophthalmology. Obviously, everyone is frustrated by what's going on. Those of us who are part of the RUC process feel that this is inappropriate. It goes against the historical norms of the RUC, the rules of the RUC, if you will. At the end of the day, the RUC really has no power. It is just an advisory body to CMS. And CMS is now under this legislative mandate to find $1 billion. And it's hard to find $1 billion when a big chunk of the physician fee service schedule is off limits, and that's E&M services. So there you saw the graph that showed how other specialties have been adversely affected, and now ophthalmology is going to see a similar fate, I think, over the next few years. In a way, we were just unlucky that it was our codes coming up at the same time that this $1 billion mandate came into effect. But it is the new reality, and we're going to have to deal with it. We think that there may be some opportunities through what's called the refinement process, and we're going to pursue that. Frankly, I don't think anyone is very enthusiastic or optimistic about the possibilities of that being successful. So it's a different world going forward, and we all have to recognize that this is part of a deliberate process to reallocate payments from specialty physicians, from surgeons to primary care. And you can argue that, but that's essentially a political decision. It's not at this point, not a policy decision. So again, if there's any questions, we're all in this together. The Academy values its work with the AGS. We think that there will be other issues going forward. We know that imaging is going to change, the reimbursement for imaging. OCT was just reevaluated. We're going to wait and see next year what the final numbers are for optic nerve OCT along with retinal OCT and anterior segment OCT. Fundus photographs are going to be cut next year. In 2017. That's part of the transition from film-based to digital costs. We're going to see a significant cut there. So I can't tell you the news is going to get any better, but we're going to continue to fight for reasonable values for all of ophthalmology.
Yeah, I'm just curious, what do the surveys show about the typical or average number of post-op visits for trabeculectomy these days?
So I will give that back to Cindy because she was actually sitting at the table discussing that.
So even the original code had 9 post-operative visits in it, and we retained 9 post-operative visits. The difference is that the value, the level of those codes, and just like a level E&M code translates into a monetary value, the same thing happens in those post-operative visits. They are E&M codes, but we are only able to access level 2 and level 4 E&M codes. In the old days, they were using level 4 E&M codes, so you can see there's reduction in that part of the code as well. But we were able to explain our case to the RUC. They got it. They know that trabeculectomy, that the surgery is the beginning, and that the post-operative visits are critical to success. We didn't get much pushback from that, even though the codes were targeted for just that reason, for having so many post-operative visits. In all of other specialties in medicine, there are very few high post-operative visits like ours with a 45-minute intra-service actual surgery procedure. So that's why we were targeted. But we were able to retain that. We didn't retain quite as many for the complex code. Yeah.
So this new process will also have implications for new technology. As different ways to filter eyes come online, they're going to have to be valued. And when they get valued, they're going to have to be compared to the standard procedures. They're going to have to be within the family, if you will. So keep that in mind as different devices come on, that it really does expose the family of codes to further scrutiny. And that's something that I think you need to consider going forward. Right now, we have a situation where the code, what's canaloplasty? 66174. Canaloplasty 66174 and 5 is actually now paid more than for your trabeculectomies. And when those were initially valued, they were less. So don't be surprised if somebody in Washington says maybe we ought to take a look at those again. And those may come up anyway because they're relatively new technology, even though they were just revalued.
Yeah, I mean that's part of the strategy for our comments and all of the other things that we're planning from the AGS and the Academy partnering with us to make formal comments to CMS about our objections to this. We have to be very careful that we don't incentivize them to look at other codes within our specialty less favorably as well. Don't want to add anything to the fire. So, all right, yeah, and the AGS is committed to making sure that our voices are heard by CMS and that we don't approve of how they came up with their valuations, and that we think that we have an important role to play in public health and preventing blindness in very vulnerable populations. So we have a number of ways that we're going to try to raise awareness that this has definite impacts on our patients. Okay, if there's no other questions, I'll hang around for a few more minutes if anybody wants to talk. All right, thank you.